It's a great question. You know, of course, regorafenib is son of sorafenib, and so they're almost the same molecule, maybe a little more more powerful. I think the NCCN guidelines haven't changed yet in terms of adding regorafenib as a second-line option, largely because we hadn't seen the data set. Who were these patients? You know, is it really just continuing sorafenib under a different name? But the data just is out in Lancet, and we've seen it, and it will be revisited. So I expect it will change the patterns of care. In general, at our institution, we will go to something experimental before we'll go to regorafenib second line, at least so far. But if patients aren't suitable for a study, I can imagine regorafenib getting a place. Again, the data is compelling that it adds on the back end of sorafenib in patients who tolerated sorafenib. I mean, theoretically, the study that should be done is progression on sorafenib, continue sorafenib, or switch to regorafenib. They're not going to do the study. But that's the question. Is it really more of the BEV beyond progression, kind of continuing a drug and not losing the benefit that you gained? Much as we see, let's say, with imatinib in GI stromal tumor, the TKIs, if you stop them, the disease progresses more rapidly than if you continue them, even though the disease is progressing.